Good morning, Dr. Johnson. I just read an interesting article about the updated management of post-cardiac arrest syndrome. Have you had a chance to review the new guidelines? Good morning, Dr. Smith. No, I haven't had a chance to go through the guidelines yet. Could you give me a brief overview of the updates? Of course. The new guidelines emphasize the importance of early initiation and optimization of targeted temperature management (TTM) in patients who achieve return of spontaneous circulation (RSC) after cardiac arrest. They recommend maintaining the target temperature between 32 degrees Celsius and 36 degrees Celsius for at least 24 hours. That's interesting. So, they're still recommending TTM, but have they made any changes to the target temperature range or duration? Yes, that's right. The previous guidelines suggested a target temperature of 32-34 degrees Celsius, but the new guidelines have expanded the range to 32-36 degrees Celsius. The rationale behind this change is to provide a more individualized approach to TTM based on patient characteristics and the underlying cause of cardiac arrest. That makes sense. It's important to consider the patient's specific needs when managing PCAS. What other updates did you come across? Another significant update is the emphasis on early coronary angiography and revascularization in patients with suspected or confirmed acute coronary syndrome as the cause of cardiac arrest. The guidelines recommend considering immediate coronary angiography for patients with St. segment elevation on the electrocardiogram (ECG) after RSC. That's an important point. Identifying and treating the underlying cause of cardiac arrest is crucial for improving outcomes. Did the guidelines mention anything about the use of extracorporeal membrane oxygenation (ECMO) in post-cardiac arrest management? Absolutely. The new guidelines highlight the potential benefits of ECMO in select patients with refractory cardiac arrest or cardiogenic shock. They suggest considering ECMO for patients who fail to achieve RSC despite optimal cardiopulmonary resuscitation efforts. That's an interesting addition. ECMO can provide temporary circulatory support and improve oxygenation, which may be beneficial in certain cases. It's good to see the guidelines acknowledging its potential role. Yes, definitely. The updated guidelines also stress the importance of a multidisciplinary approach to PCAS management, involving critical care specialists, cardiologists, neurologists, and other healthcare professionals. It's essential to provide comprehensive care to these patients and address both cardiac and neurological aspects. That's a crucial point. PCAS management requires teamwork and collaboration among various specialties. I'm glad the guidelines are emphasizing this aspect. Absolutely. Staying updated with the latest guidelines and research is vital to providing the best possible care to our patients. I'll share the full guidelines with you so that we can discuss them further and incorporate any necessary changes into our practice. That would be great. Let's review them together and ensure we're providing the most up-to-date and evidence-based care for our post-cardiac arrest patients. Collaboration and continuous learning are key to improving outcomes in PCAS management.